Good morning. I'm Gordon Smith, the state's Director of Opioid Response. We appreciate you participating in today's webinar. I'm going to give it just about another minute as people are getting into the room and getting organized. So you are in the right place. I'm just going to give it a few more seconds here. We're well over 100 people. We probably will have 200 to 300 people with us today, which we really appreciate. All right, it looks like those that are ready are ready. And I'm going to make some announcements. And then, as you know, the purpose of today's monthly webinar is to receive input into our existing opioid response strategic plan. I'm really excited to have with me today the acting director of the Office of Behavioral Health, Sarah Squirell. And Sarah will make some comments after my comments this morning. And Carol Kelly, who is with Pivot Point Inc. in Portland. Carol's an independent consultant with us who's been retained by the generosity of private philanthropy to help us put together this plan, which is great because she also helped with the plan on the two previous occasions. So I also want to comment on our next two webinars. On Friday, November 4th, we're going to feature the topic of our recovery community centers. We now have 16. We expect before the end of the year to have 19 or 20. And we're really committed to having at least one in every county. And we have accomplished almost all of that, and expect centers to open in York, Franklin, and Piscataquis before the end of the year. And we're talking to Waldo and to Somerset counties. So Mike Freisinger at the Office of Behavioral Health will lead that discussion, and we'll have some guests from some of the recovery centers. I think it's important because of the resources we're putting into recovery centers to have a program on, well, what are they? And what is their purpose? And what do they do? How do they differ? And what's the future? What's sustainability in Maine? So we're looking forward to that. We will have our final webinar of the year on December 2nd. And we've not yet chosen that topic, but it will be on December 2nd. And these are all 11:30 to 12:30. Today, we have the opportunity to extend the time to 1 o'clock so that with as many people as we have involved, about 150 right now, and many of them interested in commenting, we want to give people more time. And we do want to take a moment, probably 10 to 15 minutes, to give a very high overview of the plan, as well as Acting Director Squirell will talk about how our existing strategic action plan is integrated with the Office of Behavioral Health and their plans and all of that. Technically, let me tell you how this is going to work, because this is a little different. You've all been sent a link to the plan. Many of you are familiar with it. I'm pleased to say that it's not 100 pages. It's about 12 pages. It's the 10 priorities, 33 strategies, dozens of activities. I know that virtually all of you have had a chance to look at it. If you wish to make a comment on the plan, then you can, we ask that you put that in the question and answer portion of the Zoom screen, and not use the chat. We've done that because if you use the chat, then people can comment on your comment. That's not why we're here. We're here to hear your comments that you would like to present to us. I would, and then if you wish to present to us orally, which is fine, we'd love to see you and hear from you. We would ask that you only do 3 minutes, because we want to give everybody an opportunity to have that chance. And I'd ask that you raise your hand in that portion of the Zoom screen that gives you that opportunity. In my screen today, that happens to be at the toolbar at the right and where the three little dots are. But yours may be a little bit different. But you raise your hand, and then our moderators, Carol and Lorena, the Liberty from HadCare, will let you in when it's your time to present. And then you will be, when you're done, you will be muted, and we'll leave the panel piece and go back as a regular attendee. Many of you are familiar with that process from how we do things at the legislature. I would ask, if you're presenting orally, all of the attendees, of course, will hear you. Some, they will not see you, but they will see your name. And so, because most of you are quite adept at Zooming now, if you want to present anonymously, you can change your name on your Zoom screen to whatever whatever you'd like it to be, if you, again, don't want to be identified, which is fine. I would ask that your comments be respectful. I know that this subject, of course, it elicits strong passion, but screaming at us about what a horrible job we've done isn't going to accomplish, what you'd like to accomplish today. We really, and don't also expect any response from us today, because we're here to listen today. And it wouldn't be appropriate for me to say, well, that's the best thing I've ever heard, or that's really the most ridiculous idea I've ever heard. You will not hear that from us. You will hear nothing. Hopefully, I can restrain myself and just thank you for your testimony. Let me tell you a little bit about, and also let me say this. Everything is on the table today, as long as it relates to substance use disorder in the state of Maine and what our appropriate responses would be. So if you want to add things should be added to the plan. If you think we have the wrong focus, there's no filter here except for appropriateness and a respectful language. Let me tell you just a little bit about the history of the plan. This was done originally in 2019 after the governor was elected. We had a plan. Carol will remember the meeting. We had a meeting with her and some other individuals, and by September she signed off on the original plan. And then in 2020, because we got hit by the pandemic, and we worked on adjustments to the plan, and those were published in January of 2021. So it's been more than a year and a half now that we've been using the existing plan. And because the sources of the drugs change, what's in our drug supply changes, the needs change, the pandemic changes, it's something that we absolutely need to adjust at least every year, if not more frequently. So I'm going to make just some brief comments on the high-level overview of what the plan is about, and then ask Sarah to talk about how we integrate that with the other actions of state government, particularly in the Office of Department of Human Services. The whole plan is premised on treating substance use disorder as a chronic illness and not as a moral failing. There are certain values, although it's really focused on 5 different areas, and I usually talk about 4, those being, of course, prevention, treatment, harm reduction, and recovery support. And I very frequently will say that we have to be successful in all these domains if we're really going to improve the situation in the state of Maine. They are all incredibly important. You might, in your work, feel that, well, prevention is the most important thing. You may be a harm reduction list and feel that, well, harm reduction is the most important thing because if we can't keep people alive, we can't get them into recovery. Or you may be in the treatment community and feel that treatment's the most important thing. Or you may be in recovery or have loved ones in recovery and feel that supporting people in that recovery with recovery centers, recovery coaches, recovery residents is important. So they're all important, but throughout those domains, the shared values that are listed in the first page, there's really 5 of them. And we put them on the first page because they are important to all of the domains. Data, for instance, we are data driven. We've got a lot of data, and we want our responses to be evidence-based and based upon the data that we have. Reducing stigma. There's none of those 4 areas where stigma and the need to reduce stigma is not important. Building resilience in individuals across the lifespan is our 3rd shared value. The 4th one is maintaining a robust infrastructure. This is something I worry about a lot because we could have a great plan, but if we don't have the people and the organizations and the resources to implement it, what's the point of having a plan at all? And then our 5th shared value is the need to implement all these activities with subject to all available funding, federal, state, private philanthropy, and in the community. And certainly today we'd add the settlement funds. So with that, I've taken more time to say that than I intended. So I'm not going to go through the priorities and the strategy because you have the plan. Again, to me, it's all about those 4 pillars. That 5th pillar, by the way, is leadership, and leadership does matter. And the first priority is taking decisive, evidence-based, and community-focused actions in response to Maine's opioid crisis. So the leadership section is really about our annual summit, these monthly webinars, the things that Governor Mills and I and our team does every day to focus on this problem in the state of Maine. So with that, I'm going to stop and turn it over to my colleague, Acting Director Squirell, who was so fortunate, moved her family from Vermont here, where she was had a substantial position in the mental health organizations in state government in Vermont, and we're so glad that she's with us. Sarah.
Great. Thank you, Gordon. Great to see you all this morning. Thank you for joining us. It is truly an honor to serve as the acting director of the Office of Behavioral Health. Also just want to take a moment to thank Gordon for his incredible leadership and steady hand leading this important and urgent work, and the incredible leadership of Governor Mills to support it. And I think when we think about our vision and priorities for our opioid response, we continue to think broadly. We continue to think about strengthening the overall capacity of our behavioral health system tip to tail, as Gordon noted, promotion, prevention, early intervention, treatment, and recovery. And I think our opioid response strategic plan would best be categorized as comprehensive. And now is an opportunity for us to step back, to really evaluate our progress, and to have laser focus on targeted priority areas that we want to continue to advance. And as a state, I think all of our strategic planning efforts, we need to have bifocal vision that's focusing on the immediate needs in front of us, as well as setting our gaze on the future and continuing to advance both the short-term, midterm, and long-term strategies and actions that will be required to help us achieve those goals. And Gordon mentioned the great work that DHHS is doing to help support the advancement of our opioid strategic plan. And as you can imagine, many aspects of the work to advance that plan sit in various offices across state government. Our Office of Maine Care Services, the Office of Behavioral Health, Office of Child and Family Services, and of course the CDC. And I just wanted to articulate that internally there is a high level of coordination and collaboration that is happening within DHHS. We have an internal opioid coordinating council that really looks at our work across all of our offices to really ensure that we are working in a coordinated and integrated way to advance these strategies and actions. I also wanted to note, as Gordon alluded to, that DHHS is also concurrently working to implement LD 1262. And LD 1262 was a statute that came out of the legislative session last year that really charged the Department of Health and Human Services with developing a comprehensive plan for our behavioral health system of care across lifespan. I would say that this LD is also comprehensive and outlined several key areas that we'll be focusing on. Those are inclusive of promoting consumer choice, child and youth behavioral health needs, crisis services, improving care access and coordination, housing supports, reducing recidivism for those who are justice involved, access to recovery resources, workforce development, peer and family support, and continuity of care across lifespan. We are currently working internally with our respective departments to bring together into one cohesive document all of the current strategies and actions that we were advancing across DHHS. We'll be hosting stakeholder engagement sessions at the end of this month and in early November, so you can keep an eye out for those invitations. And I think we would all agree that given the co-occurring nature of mental health and substance use, we recognize how critical it is that our efforts are integrated, that we continue to strengthen the overall behavioral health system and mental health system to help support the advancement of our opioid response strategic efforts. And our work on LD 1262 will complement and support those activities that we'll be discussing today. And finally, I would just note, as Gordon also alluded to, that what's really fundamental to advancing this complex work is our ability to work together. The constellation of our behavioral health system has many, many providers, many community members, and we really need to continue to come together under this shared vision and purpose, acknowledging that all parts of our system, from the community level right up to the state level, are part of a greater whole. So I'm grateful to be here today to hear your good input and feedback, and look forward to continuing to advance this work side by side with all of you. So thank you.
Thank you, Sarah. Of course, while Sarah's been talking, I've thought of 3 different things that I meant to mention. They will be very brief, however. We have sent a survey to 10,000 of our closest friends, and many of you have undoubtedly received it because we use the list from the summit, our annual summits, and these webinars. Some of those names are from out of state. So the first question we ask on the survey is, are you from Maine? And if you're not from Maine, then we ask them to exit the survey. So it takes about 10 minutes to complete. And again, it's designed to get, to give people an opportunity who can't be with us today to provide input. And we sent it about a week ago. And I'm pleased to say that as of this morning, 828 people had completed that survey. And there is an open-ended question at the end after we ask for prioritizing the strategies and your reaction to certain parts of the plan. We also give you the opportunity to send us an open-ended note. What else would you like us to know? And hundreds of people have sent notes and very positive, very good suggestions. So including thanking us for the opportunity to input into the plan. Secondly, I want to respond to my friend Courtney's note in the chat, about this process. We've not done the update to the plan. The plan is what it was in January of 2021, and this process is designed to get input into these changes. We then will, and let me say, we intend to reach out to organizations that are particularly affected by this illness. Our BIPOC population, including the indigenous people, maternal moms that are struggling while they're pregnant, people who are using drugs actively, whether they ever have any interest in recovery or not. We want to give them a seat at the table and hear from them. People who are in recovery, people who have loved ones who are struggling and maybe haven't yet achieved recovery. So we will be reaching out to numerous organizations, and including all our internal partners within the state, to also receive input. Then we will, in November, draft our changes, present those to Governor Mills, and then put those changes that she accepts back out for public comment. It's not a regulatory proceeding, and that's kind of nice, so we don't have to put any limits on how long it takes to communicate or anything. But I think, again, we want to give people a second chance to react to the proposed changes that we have. And then we hope by January 1st to have final plan so that we can share that with the newly elected legislature and be guided by that at least through 2023. I think those are all my additional things. Lorena, do we have people that are already raising their hand to speak?
There is no one raising their hand at this time.
Okay, so you can put your comments into the question and answer. I see that some people have done that. I will then take some pieces on the plan until Lorraine tells me that somebody would like to come in and make their comments orally. Believe me, I can fill up the time, but we'd really rather hear from some of you. You shouldn't be, we're all friends in this. Don't be shy. You're not usually shy when we're together. So I really encourage you to come to raise your hand and give us some oral testimony as well. I mentioned the priority A and the leadership thing. And I should say too, that the plan, as you know, if you've seen it, is divided into things that we're doing now that are currently funded. Those are on the first column. And then we have a column for priority future activities marked as fiscal year 22 into fiscal year 23. That's the fiscal year that we're in for the state right now. I think in our updated plan, one thing we want to do is kind of a status on all the activities. Some have been completed. Some are still in progress. Relatively few in the left-hand column are completely undone and still in the planning stages. An example in strategy 2, develop a treatment and preventive workforce sufficient to meet the needs of Maine's population. Workforce is a huge issue. When we put that together originally 2019, we didn't see the pandemic coming, and that's affected just about everything that we do. But one thing that we're pleased with is that for 2 years, we tried to implement a substance use disorders learning community. And Dr. Letourneau particularly had been involved in this, our colleague in the commissioner's office. And an RFP was developed and was responded to. And now that collaborative, that community is operated through the co-occurring collaborative operated by Kate Chichester. And every week I see the kind of programs that they're putting on to help our workforce. And it's very impressive. I'm going to go on and talk about prevention, because each time we're with the governor, frankly, if she had to choose one of these 4 pillars, she would say that the most important one to her is prevention. And I think she believes that over the long term, the way that this gets better in Maine is if fewer people start down that road. And because once you are down that road, almost everybody in this Zoom understands how difficult it is to extract yourself from that. It's a difficult, insidious disease. And so we want to make sure that we're doing everything that we possibly can to prevent substance use disorders from developing. And that certainly means working from the maternal pre-birth period to age 26, when the experts say that our neuro experts say that our brains are fully developed. But we do aim a lot of our prevention programs at about the 7th grade level. And as Director Squirell was involved in this, and the governor and the commissioner, that we were just able to put $1 million additional money that we had in the prevention treatment fund aimed right at local prevention coalitions working with 7th graders in their public health districts. Because that is an age at which youth begins to experiment with alcohol, marijuana, pills. And I mentioned that at one of my talks, and a mother came up to me after and said, well, don't forget the earlier grades. I said, what I mean to say is that we need appropriate curriculum and activities and interventions and screening, like SBIRT, the screening, brief intervention, referral to treatment, at all of those levels. Universal pre-K would help, because we then get the child into an organized situation that may be the first time that we've been introduced to that child. So I don't mean by talking about seventh graders that we start at seventh grade. No, we start at the prenatal period and work up from there.
Gordon, we
So-
have some hands raised.
Great. Well, I'll stop talking.
Okay.
People will be thankful for that. And you can allow in our first commenter.
All right, our first commenter is Courtney Allen.
Wow. Courtney,
Hi, Gordon.
thank you. Thank you.
I didn't mean to be the first person, but hi, everybody. My name is Courtney Gary Allen. I'm the organizing director of the Maine Recovery Advocacy Project, or MERAP for short. We do grassroots organizing with the recovery and harm reduction community in Maine. First and foremost, I just want to thank Gordon, you and Carol and Sarah and Governor Mills for all of the hard work you've put in over the last 4 years. I hope we get another 4. So that being said, I will try to be quick going through all of what I would like to see Maine focus on in the next 4 years. I heard you talk a lot about prevention. I also agree that prevention is an important part of this continuum of how we address the crisis. One of the things that I would like us to do is really spend time with young people, asking them how they think that we should best respond to prevention and what is best going to support them. One of the things that we do have a youth caucus as part of our organizing, and one of the things that I've been talking with young people about a lot lately is they were thinking up a piece of legislation that they would like to put in. And they talked a lot about how they would like access to naloxone and more education about what to do in the case of one of their loved ones or one of their friends using substances. And naloxone was one of the things they talked about. So I would like us to think about how to best teach young people around naloxone and harm reduction, prevention, et cetera. The other thing I heard you talk about was the workforce. Agree 100% that we need to think about how best to increase the workforce. One of the things that I've been thinking about is how do we utilize tax credits for businesses? Can we expand not just people who are leaving incarceration, but also expand it if they hire people with lived experiences of substance use, providing them with a tax credit, really incentivizing the hiring of people with lived experiences of substance use. On that note, also paying people with lived experiences. We're making this kind of effort to hire folks, but also just looking at how much we are paying them. A lot of our frontline recovery coaches and SIPS providers and harm reduction specialists aren't getting kind of a livable wage. So what can the state do about ensuring that the contracts provide them with a livable wage? Always investing in recovery community centers. We're so grateful for the money that they have received from the state, but as we all know, it's not enough. So how do we better support the grassroots recovery community centers? A lot of what I've just said is cost money. So one of the things that I've been thinking about is how do we use the cannabis tax revenue? Is there a way to set aside a portion of the cannabis tax revenue to be funneled into supporting all of these wonderful ideas that I'm putting on the table? I know that we're going to need a new revenue. I know that we have the opiate settlement money coming, but it's not enough. It's a great source of money, but it's not a very large source of money. So how do we make this new revenue? I believe that don't quote me on this, fact check me, but I believe that the prevention, there's a set aside already attached to the cannabis tax revenue of 12.5%. I don't know exactly what the percentage should be, but could we think about using cannabis tax revenue as a set aside? Obviously expanding access to beds, whether that is inpatient medically managed withdrawal, inpatient treatment options like rehab and housing across the state of Maine. Maine has invested in recovery housing wonderfully. Obviously, we need more of that. The other thing that I've been thinking about recovery housing is kind of step down housing. What we see is that people resume use within a recovery house, and that's not a safe option for the other people who are in the house. So often people get kicked out on the street with nowhere to go. And how can we address that issue? It's not safe for the person who's getting kicked out, and it's also not safe for the people who are in the house. Also illegal, but we can talk about that later. I'm almost done, I promise. And then finally, I would like you all to consider adding a pillar, or at least weaving some justice reform into this plan. We know that the war on drugs has not worked. President Biden has, as of yesterday, is pardoning all federal cannabis charges, and has called on the governors across the nation to do the same. I would like us to start considering, how do we pull back the war on drugs? Is it, of course, I would like the governor to pardon all cannabis offenses in the state of Maine, but also continue to join us in our efforts to decriminalize personal possession of substances. I believe that substance use disorder is a disease, and I know that many others on this call do, and that to have substance use disorder, you must use drugs, and to use drugs, you must possess drugs, and so we should not be charging people with minor possession of substances. And I think I'm done. I could go on forever. Thank you.
Courtney, thank you for your comments, but also thank you for your advocacy. Lorraine, I'm going to assume that we have more people with raised hands.
Yes, we do.
And so let me say that while Courtney was speaking, I lost her for a couple of seconds and got the terrifying message that my internet is unstable. So I may reset my router if that happens again. So I would be leaving you just for a brief time with Lorraine Liberty, Carol, and Sarah, who are more than capable of substituting for me briefly, but I wanted to mention that. Who's our next speaker, Lorena?
We have Stephen, and here he comes.
Great. Welcome, Stephen.
Yes, hi, Gordon. Steve Wade. I'm the Consulting Executive Director for the Brain Injury Association in Maine.
Nice to hear from you.
Appreciate the opportunity to share some comments. I just was wondering if it would be possible to consider adding into the state plan the connection between surviving an overdose and brain injury, particularly anoxic or hypoxic brain injury, which can be a sometimes subtle and sometimes very severe outcome of an overdose. So again, just recognizing this as an issue and an issue that is pretty much unrecognized by many of the folks working in the field. I think there's some perhaps some specific things that can be done around staff training and education, certainly family education, perhaps screenings, different types of screenings to identify brain injury or anoxic brain injury or hypoxic brain injury, and particularly its impact on treatment. The frontal lobes are the most sensitive to oxygen deprivation, and you need a functioning intact frontal lobe to be successful in treatment. So some recognition of the impact there. So anyway, I think the main point is just some consideration of this issue, within the state plan, and maybe some specific things that perhaps could be accomplished. So thank you very much for listening to my input on that. Appreciate it.
Well, thank you, Steve, and thank you for the work that your organization does. And it's a common event that is not well recognized. I don't have a clinical background, as most of you know, but what I do know is that this year we'll have about 9,000 overdoses, in which the individual survives. And so Steve and his organization would probably know on a percentage basis how many of those individuals we might expect to have an acquired brain injury as a result of being without oxygen for some period of time. So it is a really important issue. And I appreciate Steve bringing it to our attention. Next, Lorena,
Next, we have Lynn.
welcome, Lynn. I can't hear Lynn yet.
Lynn is muted.
Okay, Lynn, could you unmute? And then we'd love to hear from you.
She's unmuted, but I'm not sure why we can't hear her.
Lynn, because we have other people too already with their hands raised, do we, Lorena?
Yes, we do.
So,
Wait. Is that her? Her
Lynn,
mic, she's
go ahead.
commenting that her mic's not working.
okay, so Lynn, we're gonna take you out of the panel for now, and happy to have you try again if you get that mic working. Next,
Heather.
good morning, Heather.
Morning, how are you?
Great.
Good. Thank you for taking the time out to do this. It's amazing. Truly appreciate it. So I work for the Penobscot Nation Health Department for the Nalassi MAT program here on Indian Island. And we also do a telehealth program with the Micmac tribe. And previously before that, I worked with the Passamaquoddy tribe at Indian Township doing MAT work as well. And some of the things that we've been noticing is that there is not a lot of youth treatment options here in our state. Actually, we are paying to send someone to Oklahoma to a facility run by the Cherokee actually here shortly for treatment. And we're definitely identifying that there is a need within youth in the communities. And a couple of things that I was wondering is if it has been considered. So some of the children born are not eligible for ICWA services. So they, when social services needs to get involved, they're actually under the state social services. And I was wondering if there's a way to get more involvement with maybe a tribal liaison to kind of be there to help with kind of some input and things like that to make sure that traditions and culture are really being thought of when placements and involvement for the child and things of that nature. And we just took the training that just took place for the maternal and child health substance exposed infant virtual conference. That is a mouthful. And there was some really upsetting statistics in there. And I noticed that there's a higher rate for Native American and Alaskan populations with mortality rates, with substance exposure. And I was wondering if there was going to be any grant money or anything that the state plans or is able to do to kind of help with that, to fund programs to work with. I know we have the Maine Mom program, and that is phenomenal. Trying to look to see something like that available that is more geared to the tribes and keeping it with the culture.
I want to make sure you finish your comment, Heather, before I comment.
Thank you.
Okay, well, thank you for your comments. There are a lot of things happening on the adolescent treatment side, and certainly that was recognized early on as a deficit. And so the Maine chapter of the American Academy of Pediatrics has a Treat Me program where we're trying to make more of our healthcare professionals comfortable with treating adolescent SUD, because we do see unfortunately use and development of the illness at earlier and earlier ages. And we do have a plan to reopen the girls' facility at day one, and we absolutely need more adolescent care, and we have plans to do that. A lot of good work being done on that. Much of it from Child and Family Services as well. On the tribal issue, I meet every other week with Wabanaki Health and Wellness, and but we have been really focusing on adults, be honest with you, and the tremendous work that they're doing for all the tribes in the Bangor to Millinocket region. But great points that you've made, Heather, and yes, we're not forgetting our tribes, and we're not forgetting our adolescents. Next commenter, Lorena.
We have Ruth.
Good morning, Ruth.
Hi, good morning, Gordon, and welcome everybody, and thank you so much, everyone, for the work that you do and for your commitment and focus on substance abuse in general, and especially with the opiate situation in the state. I have a couple of things that come up whenever we're asked for information. Oh, by the way, I'm the president of the Maine Association of Addiction Professionals. That is, and I sit on the board of directors of NADAC, the National Association. I represent the state. And so one of the things that comes up a lot is that sometimes when we go to trainings, which lately have been quite excellent, I have to say, but there are not substance abuse professionals on their in their presentations, or like they were consulted about things. One of the reasons that some of that happens is that substance abuse professionals are not always looked at as specialists in their field. And we are specialists in our field, just like a podiatrist, just like a dentist. We are trained specifically in what we do, and we are required to get more training and have stricter ethics codes than some of the other, the LCPC or the LCSW. Our codes are more restrictive, and our training requirements are higher. One of the reasons why it's important to include us is because I used to be an examiner for the licensing board, and the people that used to fail were folks that were in psychiatry or in social work, because what we do is very specific. And when we are trained, we look at a lot of things through the lens of addiction, which is a little bit different. So everything that we plan and we do looks through that. Things like I was like being a first responder for emergency situations, for going with the Red Cross. They never think about people not having their methadone or their Suboxone. They don't think about people in withdrawal from alcohol that may be agitated and they have no clue why they're acting the way they are. They're in withdrawal. I love what Stephen mentioned about traumatic brain injury. That is so important. Addiction professionals know about that a lot, because we know that overdoses cause brain injury. There is not very much understanding about post-acute withdrawal syndrome. That is really important for people to understand, because it impacts the treatment plans that you do, and it also impacts some folks that are not trained in addiction that attribute behavioral problems to the client's treatment when it's not behavioral, it's brain injury and it's brain healing. And people in other disciplines don't understand that. There's also training the clergy. I mentioned that in my when I did the survey. Training the clergy, especially in family systems and addiction, because a lot of times the clergy are the first people that families go to. They're the first people that they talk to about, what do I do? My kid's out of control. What do I do my husband's drinking, my wife is drinking or using or whatever. And the clergy are not trained specifically in addiction, and just to have, not that they become counselors, but just so they have some knowledge of what they might be looking at and how the family systems work when they're impacted by addiction. And the other thing, which is part of my soapbox, which I'm going to say and then I'm going to stop, managed care has made such an impact on the amount of work that we must do, and addiction counselors and addiction professionals are not paid at parity with other disciplines. Somebody mentioned that already. That is really important. The other thing is, and I was just talking to someone about it yesterday, she does 1 hour with a client and then has 20 minutes of paperwork. I'm not willing to compromise my client care for paperwork because the clients are more important. They're the ones that we work for. And so if things are so difficult that people can't keep up with the demands of managed care, that's really hard for folks. And very hard for new clinicians that get burnt out really fast. It's very hard for them. And I understand the workforce development. Originally with drug treatment, people came through the ranks. They were in rehab, they got trained, they went through special programs, they became counselors. Now there are a lot of different requirements to try and make addiction professionals more on the level of social workers and professional counselors. But what it has done is made the workforce smaller, and unfortunately, myself included, we're aging out. The counselors that we have now are aging out, and unless we do something to bring younger people in or make it a little bit easier for them to get into the field, you're going to run out of counselors. So, okay, I'm done.
Ruth, all good, tremendous comments, and thank you. Next,
Sally?
welcome, Sally.
Hi, Gordon, Carol, and Sarah. I will try to be brief because I put a bunch of things in the Q&A in the chat, and I don't know where those are going. So I just want to say thank you for doing this. This is a really great opportunity to hear from other folks. I am a substance use prevention specialist. I have over 30 years experience in it. I'm also on the National Advisory Council for SAMHSA in prevention. And I'm saying that not to make a big deal out of it, but just to say I know the field of youth substance use prevention. And I love that we're all part of this. And I love that Ruth shared what she just shared. I want to get in touch with Ruth because our field of prevention, public health also, I think, suffers a little bit from some misunderstandings and not getting recognized. We are the folks in the community doing primary prevention and bringing people together, and we're the ones that have prevention specialist certification and public health backgrounds and degrees. We are the only, the coalitions in Maine are the only ones that have that in any kind of formalized way. And we are also the only group of people that are required by our funding to bring people to the table, like the faith community, like law enforcement, like EMT, like recovery, treatment, healthcare, schools, youth, parents. And so unfortunately, I found over the years that folks in the treatment field and in the recovery field don't necessarily even know who we are or what we do or understand it. And so I just want to say that anything I said in the chat was not meant in any way to offend anyone. I just wanted to say one of my main concerns is that in the strategic plan and in conversation, we throw the word prevention around quite a bit. But really, when people talk, what they probably mean is overdose prevention, death prevention, and that's great and important. And as I said in the chat, our coalition works on everything from the little kid who hasn't tried to the folks in recovery that want to get back and give back to their community and everything in between. But we need to be really careful, in my opinion, that when we use the word prevention, we're specific, because what's happening at the federal and state level is that legislators are funding what they're calling prevention, but they're funding treatment and recovery. And that's great, and I'm not complaining. But we want to remember that if the governor and the folks on this call really care about primary prevention, we need to be very specific about it. I looked through the strategic plan and I saw the word prevention used many times, and I did a search, but in almost all cases, it was not primary prevention. It was an intervention, again, very important, or it was overdose prevention. I saw mention of prevention around ACEs, but in the description, it was an intervention. And it sounds like I'm being a semanticist, but it's a really important thing because we need to be really clear on what we're doing and the evidence for what we're doing and the funding being used appropriately. So I would just suggest that the word prevention is used a lot in the strategic plan, but in most cases, except I think for for me, it really is not talking about primary prevention. And then my other comment is I would hope that the coalitions that are already doing this work would get some support for this work. And I also was curious as to why the public health districts were not mentioned at all in the strategic plan, because right now the state is reorganizing how it does its public health work, where the districts will have some organization and funding to do public health work and prevention, and then the coalitions at the local level will have some, probably not as much. So those are my comments. I do appreciate this, but I just wanted to use the time to say things that maybe don't sound as positive, but what you're doing is of course very positive. And I'd love to get in touch with people that have already commented, Ruth and Courtney in particular. So thank you for sharing your emails, and I shared mine. Thank you.
Sally, don't go away. I have a question. And a lot of what I've learned about prevention, I learned from you and your colleagues, and the prevention task force that we had in 2019 that you attended, and we did learn a lot in that year of those meetings.
Yeah.
Would it be helpful, do you think, if to at least somewhere in the plan maybe define and distinguish between primary prevention,
yes,
secondary prevention, tertiary prevention?
Yes.
Okay.
Yes.
Well,
And there are great graphics. I always use this graphic. I don't even know where it came from, but it really shows how all of us on this call are tied together. You know, it starts out with education and health promotion, and then it moves into, you know, targeting the individual, an intervention for some youth that's already using drugs but doesn't need treatment yet. Then it goes into referral to treatment, then it goes to treatment, then it goes to recovery. And really it's this big circle. And I get frustrated that I don't know that the folks in recovery, for instance, always appreciate their role in prevention and how the things that they need to stay sober and clean are the things that we need to put in place for our youth. Positive connections, community service, giving back, having people you can talk to, feeling like you matter in your community, et cetera, et cetera. So, you know, as much as we can do, yes, Gordon, thank you, to defining what we mean by these different terms, but also to bring us all together so that we're not competing for funds or competing for attention, so to speak.
Thank you, Sally. Appreciate
Thank
your
you.
help.
Thank you for letting me speak, Gordon. I appreciate it.
Next, Lorena.
We have Lynn.
Hey, Lynn. This is the Lynn that had a problem with the microphone.
Unmute. Okay, how's that? Yes, I can see myself talking now. Great. I am over 25 years in sobriety and recovery, And I've learned both sides of this coin a long time ago. And we need to start talking with Stop the Stigma. There's a movie out called The Anonymous People, and it's people everywhere from Dick Van Dyke, who's almost 60 years in recovery, talking about it. We need to stop the stigma. We need to talk to children as young as 5 years old. If mommy and daddy are, acting strange, not loving, and or somebody else, because they're using. And it's the children that we need to start in talking to, help them feel that they are not alone. Because I always felt nobody else is going through this, nobody else. And of course, I've learned since then. And, it's just, that's where we need to start talking to people, because, and then help them along the way. Tell them when they call in, say, it doesn't matter how they're acting, please come here and I'll help you. And yes, we need to have a lot more detox centers, a lot more places that they can go where they're not going to feel like they're canceled out for any reason. And so that's what I definitely learned in my classes at UMA. Yes, I am also a mental health caseworker, and I've just, like I said, learned this from an early age and learned in my classes that we need to, stop the stigma. Thank you.
Thank you very much, Lynn, and congratulations on your recovery, continuing recovery. Next.
I do not have anyone with a hand raised right now, so if someone wants to raise their hand, we will grant you permission to speak.
We'll give you a couple more minutes before we
Oh, here
sign
comes
on and
one.
out. Somebody's coming on.
Yeah, Brian.
Hey, Brian, good morning.
Hi, can you all hear me?
Yes, fine.
Great, it's nice to see you all. I'm Brian Townsend. I'm the executive director at Amistad, and we run several recovery-focused programs in Cumberland County and also in the Mid-Coast. And I wanted to avoid being redundant, so I've been listening very closely. There's a lot of really good points that have been raised. I do want to reiterate just gratitude for the scope of this plan and the reality that it confronts, that there's so many fronts that have to be tackled at once. That's never not true, but it stands out, I think, when when any organization, and certainly when a state recognizes that and also builds a concept and a strategy around that, and makes investment in that direction. It's just very meaningful. I will say, for Amistad, our focus in working with adults is certainly more on the curing, treatment, recovery end of the spectrum. And just one thing I would add in seeing all the focus that's in this plan around harm reduction, which is wonderful, is that one thing I know we all share a responsibility in is just holding these multiple dialogues and communications at the community level with folks about what harm reduction is. And I know in order for the state to achieve its goals in that place, the state certainly has a role in that. And I think as community members and providers will certainly hold a role too in trying to evolve the sort of public perception of harm reduction. And I think replacing some of the inaccurate and unhelpful images that people associate with harm reduction with newer images that better reflect the philosophy and the outcomes that we're already seeing, even with sort of the initial phases of investment in that area. So I guess that's an encouragement for the state to continue to lean into those conversations and to lean on us as providers and individual community members to help shape those dialogues. So thank you.
Thank you, Brian. Thank you for what you and Amistad does every day. Appreciate it.
All right.
Any other raised hands, Lynn?
Yes, we do. Jana, I believe, if I pronounced that wrong, I'm sorry.
Good morning, Jana.
Good morning. Thank you. I had a question. I put it in the chat, and I may have missed something along the way, including in the survey or in the plan, but I wondered if there is a plan to either a plan, sub-plan to address what I see as, like simultaneous epidemics, the twin epidemics of alcohol use disorder and opioid use disorder. Not what I see, that's what I'm getting from the, national experts. So including, I think, presentations from CCSME and those. So thank you.
Thank you. I'm going to ask Sarah if she'd like to comment on that. I frequently am asked about alcohol, and even though the word opioid is in the title of my position, this is not, our work is not all about opioids. And we have absolutely done a lot of work on stimulants. We even have a meth task force. And this is about addiction. And it can start with nicotine, alcohol. I'll throw gambling in because gambling can be an addiction. So I want to just assure you, Jana, that we do not simply forget about alcohol because it's a legal product. We don't forget about marijuana just because it's a legal product. All of these things can lead down that path to more serious to serious issues. And of course, our middle school students do generally start with alcohol when they're beginning to experiment and beginning, if they have had trauma, adverse childhood events. Alcohol is almost there, always there in the mix of things, as is marijuana. So again, I'm not a clinician. I really know nothing about what I'm talking about. So I'm going to ask Sarah, who actually has a background educationally in this field, if she'd like to comment on how we put alcohol use in this mix.
Thanks, Gordon. Thank you for the great question. And I agree with what Gordon has said. It really is, our overall opioid strategic plan is inclusive of efforts to address alcohol use, other drug uses, as he mentioned, particularly in our youth and young people. I would also say that I think we could more fully articulate those efforts more clearly within some of the work that we're doing, particularly at DHHS and the Office of Behavioral Health. And I wonder if LD 1262, our behavioral health strategic plan, would also provide us with an opportunity to provide more front-facing clarity related to the work that we are doing specifically to address alcohol use across the state. And many of our efforts, particularly in our school-based health work, are really focused on that in particular. So I would just say I agree fully, and I do think we have more opportunities just to more fully articulate those in our respective plans.
Thank you. Next, Lorena.
Next, we have Caden, a 16-year-old here in Maine.
Welcome, Caden.
Hi. So I'm part of the youth community in Augusta. And I just wanted to say that you guys are not wrong about alcohol being in the youth. It's really everywhere. And it's like a lot of people are getting peer pressured into doing it. And I've seen a lot of my good friends fall down that road and kind of use it in the wrong way. And it ruined their life. And I really don't know what to say more with that, but I really think we should like teach the youth and like younger kids about like what this stuff is, like what's alcohol, what it can do to you, what's the long-term effect. And the same thing with drugs, because when I was growing up, I was shielded from it. I didn't really know what it was. So I went out and I tried a couple of things, and it was a bad experience. And I wish I knew from a younger age to never try that stuff ever.
Well, Caden, can I ask you a question?
Yeah.
At what age do you think that we should be introducing those subjects to students? Where would you have liked to have begun that education?
Middle school, because that's where everything really started. It was all like vapes. Everyone was like, yo, come in the bathroom, come rip my vape. I got addicted to that quick and I quit. And then when I got into high school, it was drinking. But I think it should be like middle school that you should like start learning about that stuff, because I wish I did.
Right. Well, thank you, Caden. I know you're active in that youth group, and we so appreciate your speaking today and all your activities. Thank you.
Yeah.
The other point I would make is that we know that there's evidence that, I suppose it's a form of harm reduction, but the longer that we can delay the first use of substances, the less likely that addiction to those substances will occur. So if instead of taking that first drink with a group of peers at age 13, we can move that up to 19, it's a huge difference for total. So thank you, Caden. Anybody else, Lorena?
Yes, we do. Leela would like to speak.
Great. Good morning, Leela.
I'm unmuted now.
Yes, we can hear you.
Great. Thank you very much. I've been part of these seminars now for 2 years, 2.5 years.
Well, thank you.
And I've been in the field of addiction treatment for over 20. And I really wanted to speak about the recovery centers. I was really excited about it when they first began opening these centers in the underlying communities, or rural communities, I should say, especially I'm in Aroostook County. And I think it's, everything was intended to be welcoming for anybody to just walk through the door, for them to have a place to go, to ask the questions without feeling threatened or judged. But my concern is, and I'm really happy to hear that we're going to have them in all counties, is that, recovery doesn't work just from 9 to 5 during the day. And I see a lot of these centers not being utilized to their fullest capacity or ability. When I worked in an agency, groups are all tailored around the hours that a person works in substance abuse in that agency, and not around the hours that a person can be available to go to those groups. We're working with people on a regular basis to try to get some normalcy in their life, which means holding down a job once they're stable. And, they can't be asking their boss for, 3 hours off a week or 9 hours a week if they're in an IOP during work hours. I mean, I think that's what excited me about the recovery houses centers in the first place, is that they could work around people's, off hours from work. And I don't see that happening. And it's disturbing to me, that we're trying to run this like a regular business, and you can't do that with people who are trying to put their lives back together. And is there some kind of regulation around how these centers are operated, or is it just at the discretion of the agency that funds them. I guess that's a big concern for me. And for somebody who just knows that people need to feel like they have a place to go, that's safe, that they can get the information that they need. So that's my big thing.
Well, Leila, thank you for that. And I will respond. Sarah may want to comment as well. Just to answer your question, while they're not licensed centers because they don't provide treatment, they refer, we have, it's a safe spot for support group meetings. It can be a drop-in center. There can be a lot of opportunities for families there. They are nevertheless, if they accept public money, we have contracts and contractual obligations with respect to those that receive money from Sarah's agency. And so there is an ability to put in those templates, a requirement to deal with what you've mentioned. So again, there's 16, soon to be 19. They're all well intended, but they also all have a certain culture of their own. And you'd almost want that. You want the Millinocket Center to be, really embraced in that community. So I understand exactly what you're saying, and I think it's something that those folks within our agencies working with recovery community centers, as we continue to grow them and support them, we can absolutely look at that. An analogy that I think of is that I had the opportunity to speak at an open house at one of our opioid treatment programs recently. Those are for those on the call that don't, those are methadone clinics. But they also, all of our methadone clinics now do offer some Suboxone too. But they open by 5 o'clock in the morning in order to accommodate the fact that people can hold a job and many of them have to go every day. So our centers should be no different. We should be absolutely accommodating the needs of the people we're trying to serve. And I so appreciate you, Leila, bringing that, making that comment. Do we have more, Raina?
Yeah, we have a couple more.
Sure.
Lynn is next.
Okay, Lynn.
Hi. Yeah, Caden is very right. I started when I was 11 years old, and addiction starts with a traumatic event, and people are trying to forget what happened with abuse, no matter what kind it is, and that's exactly why I did. Of course, I realized it later, but it's just always running from the abusive situation, the problems that are arising, the chaos in the family, or anything else, homelessness, kids being kicked out of the homes because of, coming out, it's just a lot of trauma is actually the addictive force. And so that's why I talked about it should be 5 years old that we talk about these things, all of that. And I do like the fact that I was just recently reading that it should be mandatory that police officers, law enforcement are mandated to learn these things so that they don't just go ahead and, pull a gun on somebody that might be having an anxiety attack or a traumatic event. Thank you.
Thank you, Lynn, for those comments. Got one or two more, Lorena?
Yes, we do. We have Susan Berry next from the Department of Education.
Hello, Susan Berry. Thanks for joining us.
Hello, everybody. Can you hear me?
Yes.
Okay, good. Yes, thank you for having me, and thank you for having this open forum. Much appreciated, and it's been great to hear from everyone. I certainly, as a person who's in primary prevention, appreciate hearing all of the comments around the importance of that prevention and foundational information. I did put my comments into the Q&A as well, But just wanted to take the opportunity again to also say thank you to Caden for sharing. It's so important. And I think what I heard, one of the things I heard through listening to Caden is I want to just reiterate the importance of health education and health education at the elementary level as well as the middle and high school level. I think we have a good hold on it in Maine and the high school level. We have room for lots of improvement in getting middle school health education in place, which teaches so many of these foundational skills around prevention of substance use and abuse, and how to manage that and how students can help each other. And then the foundational skills and knowledge and supports that they need at the elementary level. What we don't have is that the teachers at the elementary level don't have any preparation in how to teach health education and address these sensitive topics and but also important topics. So having the, if we could look at how do we get some teacher preparation in place to help our educators to deliver some of the health education content, and also just to manage and know how to best talk with their students and teach their students about these primary prevention skills and this information. I could go on, but I just wanted to make that point so I could see us putting something into strategy 8 for the coming year and or years to help support that and move that forward. Thank you. And thank you again for this forum.
Thank you, Susan. It gives me a chance to comment on the really terrific work that Commissioner Macon and your whole team, Kelly and Bear and Mary Herman and the whole group, and your social and emotional learning modules made available to every school. And the last time I looked, there have been like 15,000 downloads. And in the pandemic, that became so important. So we consider the Department of Education and all our 15 departments of state government to be really important partners in our work, and I'm so appreciative of what you do. Anybody else, Serena?
We do. We have David.
Hey, David. Good morning, David.
Good morning. This is Dave Bilodeau. I'm the options liaison for Androscoggin County.
Glad to hear from you.
I just wanted to say a few things. We recently here have got Narcan into the middle school and the high school, but I have to tell you, it was a fight with the parents, not so much the school. So I would love the idea of getting some into the hands of the children, because I've had children ask me for it because of the parents' use. But I think that education has to start with the parents to allow it in. I mean, it was a fight to get it into the schools, because the thought was, if you bring it into the schools, now people will use because they know it's there. And, with the work from the school committee, we got it passed, and we now have it in 2 of the schools. We will have them in every school in Lewiston. It's already been approved. It's just a matter of time. I'd love to do training for the kids. I'd love to give it to the kids. Kids have questions they want to know, but you can't do that without getting the parents' permission. And you got to get the parents' buy-in on it. So yeah, that's first. But I agree. I agree with Caden. I agree with everybody else. You need to bring the children into it, because that's where it starts. We were all kids. We all remember sneaking that drink or sneaking that, that puff. So yeah, it's got to start with the parents. It's really needed. The other thing I wanted to mention is through the options program, I send probably as many people for alcohol and other treatment as I do for opiates. Anybody that we go to for an overdose or follow up on, or a family member, we don't turn anybody away. Many say, I don't have an opiate problem, but I drink a lot or I smoke a lot. And we refer them for treatment just as well. It's not really publicized. It's not really, people don't know that options also helps with the other stimulants and alcohol and tobacco and vaping, but we do. I mean, we don't turn away anybody that asks for any kind of help. So maybe some public attention going into that it's not just opioids. It's whatever they need help with.
David, thank you. And it gives me a good chance to plug our options liaison program for those unfamiliar with it, OPTION stands for Overdose Prevention Through Intensive Outreach, Naloxone, and Safety. And again, through the Office of Behavioral Health, which Sarah leads, put considerable resources into hiring a behavioral health specialist in every county to reach, particularly to do outreach and to correspond when they can to our overdoses, which are not fatal. And as I mentioned earlier in this call, 9,000 of those probably this year. So David is one of our liaisons in handles Androscoggin County, and I'm so appreciative of what David and all the liaisons do, because it's really hard. It's really hard work. Anyone else, Lorena?
Not at this moment, no.
Okay, I'd like to then ask Sarah to make any parting comments, and then Carol, as well as the person who's going to be working with us to put this plan, these plan changes together. So Sarah, any last minute comments?
Yeah, thank you, Gordon. I just want to extend my great gratitude and appreciation for everyone who took the time to join us today, provide your very insightful and candid feedback related to the directions that we might head. I think we've really honed in on some areas where we have key opportunities, particularly related to promotion and prevention activities. I really do think we have an opportunity to go upstream, to intervene earlier. We know children and youth are setting long-term health trajectories in their earliest years, and I think this is a key area that we'll continue to lean into. So just grateful for the discussion. It's also given me some good insight and ideas related to our broader behavioral health strategic plan, and really would encourage everyone who has participated today to also bring your good thinking to the strategic planning sessions that will be coming up related to that as well. So thank you, Gordon.
Thank you, Sarah. Carol.
Oh, thank you, Gordon, and thank you, everyone. This has been tremendously helpful, and it's just great to see everyone as well. And I'm grateful and honored to continue to be working on this important issue. We've made so much progress over the last 6 years since Gordon initially invited me in. So I'm thrilled to continue to be part of it. I really appreciated all the creative and innovative thinking here. And I think it's really, as I look to what can be added and amended to the plan, I really appreciate this broadening of our viewpoint, including the prevention components, the primary prevention components, and really those, early use of all substances that nicotine obviously plays a role that sometimes we don't acknowledge, but certainly the last plan didn't knit in. And I wonder if there's ways we can do more of that. And really, because Maine is a place where we try stuff and we find out what works sooner than maybe the national models will show. I think just keeping open to innovations. I just hope that you all will continue to feed us ideas and pilot projects that you know of, or things that are happening that we can continue to consider as we add and refine the plan. So we want this to be data-driven and evidence-based, but we also know in Maine, we do things differently sometimes. And so we should be paying attention to that. So thank you so much, everybody. And thank you, Gordon, for pulling us all together.
Well, I want to thank both of you and also Lorena and AdCare, who does such a great job setting up our webinars with us. We're giving you 5 extra minutes in your day to help get ready for the weekend. I hope you all will join us on November 4th as we really we'll have an interesting discussion about what it means to have a recovery community center and how many hours they ought to be open. So have a great weekend, everyone, and thanks so much for sharing this input. It means a lot to us.
Hey, Lorena, do you have a minute?
I do have a minute. People are still on. I'll send you a new link, okay?
Great, thanks.